This content is AI generated for informational purposes only and should not be directly used for clinical decision-making.
Hello and welcome back to the Neurosurgery Hub podcast. I'm Dr. Aris, Senior Attending Neurosurgeon.
And I'm Dr. Alara, Research Fellow. Today we're looking at a fascinating new study from the journal World Neurosurgery 2026, titled Comparative Efficacy of Endoscopic Endonasal versus Transcranial Approaches for Treating Olfactory Groove Meningiomas, a Systematic Review and Meta-Analysis.
This is a topic that is constantly evolving in our field, Alara. Olfactory groove meningiomas, or OGMs, represent about 10% of all intracranial meningiomas. For decades, the transcranial approach, or TCA, was the undisputed gold standard. But over the last decade, the endoscopic endonasal approach, EEA, has moved from a niche technique to a primary contender.
Exactly, Dr. Aris. However, as the authors of this 2026 meta-analysis point out, the debate has been muddled for years. When we look at previous literature, there's a massive confounding by indication issue.
Let's pause there for our residents listening. Confounding by indication is a critical concept in surgical research. In this context, it means that the tumor's anatomy itself often dictates which approach a surgeon chooses. If a tumor is small and strictly midline, a surgeon might choose EEA. If it's massive with significant lateral extension or encasement of the anterior cerebral arteries, they'll almost certainly go transcranial. This makes it very hard to say if one approach is better than the other or if we're just comparing two different types of tumors.
That is exactly what the study tries to address. They synthesized the evidence while specifically accounting for these limitations. They looked at the primary metrics we all care about: gross total resection, or GTR rates, visual outcomes, and of course, the complication profiles.
Let's dive into the GTR rates. In many older series, TCA was thought to have the upper hand for achieving a Simpson grade 1 or 2 resection because of the ease of addressing lateral extensions. What did this 2026 meta-analysis find?
The data suggests that for tumors specifically selected for the endoscopic endonasal approach, GTR rates are now comparable to the transcranial approach. However, the study notes that the EEA offers a unique advantage in its medial to lateral perspective. It allows for early devascularization of the tumor by addressing the ethmoidal arteries first, before you even touch the tumor bulk.
That's a key point. In a TCA, particularly a subfrontal approach, those feeders are often at the bottom of your field, and you have to work through or around the tumor to get to them. But let's talk about the trade-offs. If the GTR rates are becoming comparable, we have to look at the morbidity. What did the study say about CSF leaks?
That remains the Achilles heel of the endoscopic approach. The meta-analysis shows that even with advanced reconstructive techniques, like the vascularized nasoseptal flap, EEA still carries a higher risk of postoperative cerebrospinal fluid leaks compared to the transcranial approach.
It's a significant hurdle. When we go transcranial, we aren't usually creating a direct communication between the intracranial space and the sinonasal cavity in the same way. But on the flip side, TCA often requires some degree of brain retraction, even with modern retractorless techniques. Did the paper touch on the neurological outcomes?
It did, specifically focusing on visual recovery. Interestingly, the meta-analysis found a slight trend towards better visual improvement in the EEA group. The authors suggest this is because the endoscopic approach provides a direct ventral view of the optic apparatus, allowing for decompression without any manipulation of the optic nerves or the chiasm.
That makes sense anatomically. You're coming from below, so the tumor is between you and the nerves. In a TCA, you often have to work over or around the nerves to get the final bits of tumor. What about olfaction? I imagine that's a lost cause in most of these cases.
Unfortunately, yes. The study confirms that for OGMs, anosmia is a near universal outcome, regardless of the approach, though EEA essentially guarantees it because you are working directly through the olfactory corridor.
So, looking at the big picture of this systematic review, what is the take-home for a resident or a fellow who is looking at a patient with a 3-centimeter OGM in the clinic?
The authors emphasize that the optimal approach is no longer a one-size-fits-all answer. They conclude that EEA is an excellent, highly efficacious option for midline tumors, where the goal is early devascularization and ventral decompression of the nerves. However, for tumors with significant lateral extension beyond the internal carotid arteries, or those with significant brain edema, the transcranial approach remains the safer, more reliable workhorse.
It really comes down to patient selection and recognizing the anatomy that confounds the choice. This 2026 meta-analysis in World Neurosurgery gives us a much clearer framework for that decision-making process. Alara, thanks for breaking this down.
Of course, Dr. Aris. It's a great reminder that as our tools improve, our clinical judgment must become even more refined.
Well said. That's all for today's episode of the Neurosurgery Hub podcast. We'll see you next time.